It is my pleasure to introduce Dr. David Systrom, who practices pulmonary and critical care medicine at Brigham and Women's Hospital. He is also the director of the Mass General Hospital Cardiopulmonary Laboratory. Dr. Systrom is an assistant professor of medicine at Harvard Medical School. And most importantly to us, since 2013, Dr. Systrom has pioneered use of the invasive cardiopulmonary exercise test as a diagnostic tool for systemic exercise intolerance, and the administration of Mestinon in the treatment of a subset of ME/CFS patients. Dr. Systrom, welcome, and we are looking forward to hearing what you have to say.
Thank you very much, Phil, for the kind invitation. One little minor correction. I direct the cardiopulmonary exercise lab at the Brigham, but as Ron Tompkins has indicated, we are collaborating closely, and of course, we are now the Mass General Brigham, and one big happy family. So let me pull this up and see if I can get this going properly. So what I hope to accomplish over the next 20 minutes or so is to introduce the group to our use of the test that Phil just alluded to, which is an invasive cardiopulmonary exercise test to investigate the mechanisms by which patients with ME/CFS have exercise intolerance. And in the way of a bit of a disclosure, as Phil said, I am a pulmonary and critical care doc, and it was a bit of serendipity that got me into the ME business. We try to evaluate all forms of exercise intolerance, and the test that I'm about to describe to you was originally developed to detect early heart and pulmonary vascular disease, but we have found it quite useful over the last several years to investigate other diseases, including ME/CFS. So here's a little table of contents about what I'll discuss. As I just said, the invasive cardiopulmonary exercise test to be used in the diagnosis and better understanding of exercise intolerance in ME. I'm going to touch on what we have discovered as an association, and I'll leave it at that for now, between some of the vascular dysregulation that we've found with the invasive CPET and something called a small fiber neuropathy, and there is an autonomic neuropathy variant of that. I'm going to touch very briefly on something Ron Tompkins brought up, which is potentially quite exciting, perhaps for a subset of patients with ME, and that is that the skeletal muscle mitochondrion might be dysfunctional and cause some of the symptoms. And then, as Phil just said, I will come back to a bit of treatment, and specifically with pyridostigmine or Mestinon. Here's a little cartoon that describes all of us when we go to exercise. And what we've got out here to the left is the mitochondrion, in this case in the skeletal muscle, but remember, any high energy tissue has these and depends on them, and that includes the brain, includes the peripheral nervous system, and many other organ systems. But with respect to exercise, what we do when we get out there in the real world and crank up volitional exercise is we increase metabolism. We produce carbon dioxide. It has to flow, if all is well, out to the environment where it is exhaled. Conversely, oxygen flows in from the environment, and there's a diffusive step here at the pulmonary circulation, and then a convective flow of oxygen here, read oxygen transport by the heart and the blood vessels, and then on out, and if all goes well, where it could be taken up and utilized by the mitochondrion. Any dysfunction of any one of these steps, breathing, heart and circulation, and or the muscle itself, can lead to symptoms, and it can lead to symptoms such as fatigue and shortness of breath, and even indirectly things like lightheadedness. So here is our lab at the Brigham in action. This is an individual who agreed to be videoed during an invasive exercise test. There's a mouthpiece in place here, which one can see is connected to a metabolic cart. We measure breathing and pulmonary gas exchange breath by breath with this system. That's the non-invasive part. This yellow piece of plastic hanging from his neck is a pulmonary artery catheter. It's really the heart and soul of the invasive variety of this test. Really enables us to get at root causes of exercise intolerance. And over here is a radial artery line. It's a short catheter in the radial artery catheter. It too helps enormously in interpreting why overall aerobic capacity might be diminished. Here's a simplified, and I will stress just one or two things here, a diagnostic algorithm that we've derived from this type of testing. Up here is the time-honored measure of overall aerobic capacity. So we can tell how any individual, how severely impaired they are by measuring a VO2 peak or maximum oxygen uptake at the mouth. It's a non-invasive measure. These numbers are expressed as a percent of predicted based on patient's age, gender, and body size, and crudely speaking, less than 80% is abnormal. As you'll see in a minute, many patients with ME are in and around this number, and they might be written off as otherwise normal or perhaps simply detrained if we simply went this far and looked at that number without anything else. I'm going to focus on one or two other things here. Many of these other things are diseases we're not going to deal with today, but they're quite useful in select patients with ME because there can be some fatigue and left heart disease and pulmonary hypertension and even COPD, emphysema. We can rule all these things in or out with this very same test. But what I'm going to focus on are two of these boxes. This one down here is something we call preload failure. This is an entity that we have discovered is essentially common to almost every ME patient I have seen, and about 800 of them now and counting. They have low filling pressures during upright exercise, and I'll emphasize the upright where gravity is the enemy. And over here is another more recently discovered entity, and that is impaired oxygen extraction by the muscle, and I'm going to come back to that in just a little bit. These are some recent data that we have in the form of a manuscript that has been submitted for peer review and publication in the medical literature. It was 160 recent patients that we saw at the Brigham, all who had the clinical diagnosis of ME/CFS. And what we did was drill down to look for different vascular subtypes or hemodynamic subtypes with the type of testing I just described. Down here, you'll see that everybody has low filling pressures. This is the right atrial pressure, again, measured in the upright position on the cycle ergometer. All these things are at peak exercise, and they are super low in three different subtypes I'm about to describe when compared to normal individuals at peak exercise. This is ubiquitous. Preload failure has been part of the pathophysiology of exercise intolerance in all of the patients essentially that I have seen that are uncomplicated by other diseases and carry the diagnosis of ME/CFS. Now, what we've done most recently is take this a step further, and we have divided the ME/CFS patients into three tertiles. So these are three different groups with a range of cardiac output responses to exercise. We measure this every minute during exercise all the way up to peak. And what we have found is that there is what we call a low flow state. This is the low peak exercise cardiac output when divided by the oxygen uptake. This is the middling group. This is a pretty normal slope of cardiac output versus VO2, and this is the high flow. They have a lot of pulmonary blood flow, and I'll come back to that in a minute, but it seems to be ineffectual. It's not doing what it should do. It's not getting to the muscle mitochondrion properly where oxygen can be taken up. Here, just to frame things a bit, is that peak exercise VO2 I just described, and you can see that by and large, patients end up in just a mildly depressed range on average, but there is some variance. Some are quite well preserved and some are not so. And the reasons for the VO2 peak being depressed are, there are two basic reasons. One is that the cardiac output may be low. That's the low flow state. And then at the other end, we have a high flow state where the pulmonary blood flow is quite high, but again, ineffectual, and that is associated with poor oxygen extraction. I will come back to that. So the basic take-home message here is when we drill down with invasive cardiopulmonary exercise testing, virtually everybody in the upright position has extremely low filling pressures. The pump is not being primed properly, and what we read is the big veins are not squeezing down properly, pushing blood back to the right heart, and the right atrial pressures are quite low. And then additionally, there is a subset of patients whose low oxygen uptake is more related to high blood flow in the lungs, but ineffectual blood flow, not getting out to the mitochondrion. So this is where these patients land in our algorithm. They have low, modestly depressed VO2 peaks, and often modestly depressed or even slightly normal cardiac outputs, pulmonary blood flow, but they all have low filling pressures feeding the right heart, and a subset has additionally poor systemic oxygen extraction. So an interim summary here is that our invasive CPETs suggest in ME that there is vascular dysregulation that underlies some of the symptoms related to acute exercise. So the next step we took was to examine these 160 patients, and you can see some of the demographics here. As everybody in the virtual room probably knows, there's a female predilection. The white race probably reflects some of the referral patterns at the Brigham, and I don't know that this is true across the board. We've got some comorbidities in some patients. We've got some drugs, but a minority of patients that might cause vascular dysregulation or even mitochondrial dysfunction. But what we wanted to know was, is there a link between the vascular dysregulation we can demonstrate during the invasive CPET and something called a small fiber neuropathy? And this we've done with the help of Ann Louise Oaklander and her lab at Mass General. It's a minimally invasive skin biopsy that we do just above the ankle. And about 3 weeks later, we learn about the skin density of the neurites. And these are the small fiber unmyelinated or lightly myelinated fibers in the epidermis, the superficial layer of the skin. And the interesting finding in this study was that virtually a third of patients have definitive small fiber neuropathy to go along with the vascular dysregulation that we have found with exercise testing. And an additional substantial percentage has a low normal value for neurite density in the skin, suggestive of, but not diagnostic of, small fiber neuropathy. So this is a number, meaning approaching 30, 40% of patients, that is very similar, frighteningly similar to the prevalence of small fiber neuropathy described in fibromyalgia and in POTS. So it appears to be common in ME/CFS, not unique to ME/CFS, but common. We additionally tried to link naturally some of our invasive exercise test variables. This is the peak exercise VO2, the peak cardiac output, the right atrial pressures, the systemic oxygen extraction that I'll come back to the actual neurite density in the skin, and we failed miserably. So it appears that the density of the nerves in the skin with small fiber neuropathy does not dictate the physiology during exercise. But I think that what we would hasten to add is it's probably not just anatomy that counts, but it's the function or the physiology of the remaining small fiber nerves and the autonomic nervous system that probably counts. And we're pursuing this actively now with further study. So another interim summary here is that in ME/CFS, the prevalence of small fiber neuropathy is similar to that found in fibromyalgia and POTS. I'm going to briefly touch on something that Ron Tompkins brought up, and that is the notion of mitochondrial dysfunction in ME/CFS. These are very preliminary data, and it's something that our consortium is looking for further funding to study. This was a subgroup of patients, all with ME/CFS, 11 patients in the summer of 2019 that participated in a clinical trial where we were able to obtain a frozen muscle biopsy from the gastrocnemius and send it appropriately to Baylor for a variety of things and another Atlanta lab for more things. So what we're looking for in adults without a genetic history of a mitochondrial myopathy is largely electron transport chain function. This is the function of the mitochondrion, how well it can move substrate, meaning food, down the chain and generate ATP, which is the high energy molecule that mitochondria produce in the muscle and the brain and other high energy tissues. So what we found in 11 patients who had undergone the invasive CPET but had poor oxygen extraction is that all but one of them had evidence of mitochondrial dysfunction by this measure, which is citrate synthase deficiency, or the activity is decreased. So this is a biochemical marker thought to reflect global mitochondrial function. And all of these patients, remember this is a subset of the ME patients who have poor oxygen extraction, except for one, had evidence of this. And here are some of the associated abnormalities over here, shown here. This is something we truly want to develop. It is under the category of a biomarker that shows beyond a shadow of a doubt we have problems at the level of the muscle. So,
5 minutes remaining, David.
Yep, got it. So I may even beat the 5 minutes here. So an interim summary here is that poor systemic oxygen extraction exists in a subset of patients with ME/CFS. That's that high flow group. And this may be due to the vascular dysregulation that I've spoken of. We call it left to right shunting, meaning the blood flow doesn't get to the mitochondrion. It may be due to mitochondrial dysfunction, meaning the mitochondrial machinery is dysfunctional, or both. And this is something that we're pursuing actively now as part of our funding and with the consortium. All right, so the last thing I wanted to talk about was Mestinon. This is pyridostigmine. It's an FDA-approved drug that's been around for about 50 years for the treatment of myasthenia gravis. So this is an off-label comment. This is using an FDA-approved drug for something else. We think the way it may work in ME and associated dysautonomia is that what we know it does is it improves the concentration of acetylcholine in neural synapses, nerve to nerve or nerve to muscle in the case of myasthenia gravis. And what we also know is that there is a cholinergic step, meaning Mestinon enhances this, and then an adrenergic step that is subsequent and may favorably affect blood vessel tone. So we have followed up 52 patients over the course of about a year. Treatment is here in days, at a respectable dose of Mestinon and repeated non-invasive exercise testing, but the kind that enables us to look at oxygen extraction and cardiac output, again, non-invasively. Details on that later. And I want to focus on this high flow group that I described before of high cardiac output versus VO2. And what we found was a significant increase in their VO2 peak 1 year out on Mestinon. It was mediated, interestingly, not by the cardiac output, but it appeared to be mediated by better systemic oxygen extraction, which is shown over here. So we think the blood vessels may be better regulated when the patient is on Mestinon, and a majority of patients report improved symptoms. So that's the last notion I want to leave you with. Pyridostigmine may improve exercise capacity in ME, and it appears, at least with preliminary data, that this may be related to better blood vessel regulation in the periphery. We have an ongoing prospective study in our lab that's registered with clinicaltrials.gov that is looking at the acute effects of 60 milligrams of Mestinon versus placebo with repetitive invasive testing done 1 hour apart with the same catheters in place. So these are the messages I wanted to leave you with, and a quick thanks to a bunch of people who have helped me along the way, Dr. Aaron Waxman, who does our catheters, Philip Joseph, who's done a lot of the work in the high flow, low flow, our exercise physiologist, Julie and Katie, our research coordinators, Rosa Paris, who just got Department of Defense funding in the way of a discovery grant to pursue all of this, Sarah Miller, and a new arrival, Arabella Warren from the UK. And some names familiar to you, one of whom you're going to hear from in a second, Ron Tompkins, a special call out to him, and the MGH Harvard Group, and our funding mechanisms. Thank you very much.
Fantastic. Thank you so much, Dr. Systrom.